Think about. Next, I'd like to introduce our next speaker, Prof. Larry Egan. He's one of our own, graduating here at UCG many years ago. He's trained in internal medicine, clinical. Maybe I should be speaking in centuries. Clinical pharmacology, and now is a consultant gastroenterologist. When Larry was asked what he does when he's not saving lives, I believe the first thing on the list was writing grants. But he also spends lots of time with his family and exercising. So welcome to the stage, Prof. Egan.
There you go.
Thank you. Well, like the other speakers, I would really like to thank them for the invitation to speak here. It's really fantastic to have something that's a little bit different than the normal medical lectures and medical talks. So in terms of the great challenges, I chose to speak about chronic disease management. And really the central theme I want to get across today is that in chronic disease management, it does matter what we measure. Now, in medicine, in looking after people with illnesses, there are a number of different ways to make an impact. One way of making an impact is to be involved as a teacher, educating healthcare professionals. Another way is to be involved as a researcher, finding out new things about diseases, how to diagnose and prevent and treat them. Another way is to be a healthcare administrator, devising policies to minimize the epidemic of obesity, for example. But another way is to be involved as a healthcare provider. And being a healthcare provider, be it a doctor or a nurse, a physiotherapist, a pharmacist, whatever, they're very kind of special positions, and there are a lot of very good things about them. It's a very interesting subject matter. One is able to have a very special relationship with the patients. But as well as that, one of the things that I found was really good for me as an individual, as I was going through my training to become a doctor, was that I got to meet people that I wouldn't otherwise meet. I think most of us meet people kind of like ourselves in our personal lives, but when you go into the healthcare world, you definitely meet people that you wouldn't otherwise meet, and it's pretty much an even spectrum of the population where you're living. And one of the things I think that is really enjoyable about that process is that one learns to speak to patients and elicit their story from them. It can be a really, really rewarding experience. Now, the central theme that I want to bring out today really is that how we gather information from patients can really affect what happens to those patients. And I think that technology will allow us to do that in even better ways as time goes on. Now, if we look back to the time that we were students, and medical students are still taught these kind of things about how to do so-called history taking. This is one particular book which was first published in 1921, and if there are any medical students in the audience, I would definitely recommend reading this one. It's still being published. This was the 13th edition, I think, but there's at least 19 editions now. Cope's early diagnosis of the acute abdomen. And if you read this book, you'll find that Cope exhorts us to ask the patient about when the pain started. Where is it? Did it begin suddenly or gradually? When the pain is in one place, does it move somewhere else? What does it feel like? Is there anything you can do to make the pain go away? Is there anything you can do to make the pain go better? If you vomit, how often do you vomit? Does the vomit come before the pain or afterwards? What about your bowel movements? Do you have a fever? All these questions you've got to ask patients to find out about their illness. And it's a tricky thing to learn as a student. But as you go on in your medical careers, one gets used to hearing certain patterns and being able to actually make an accurate diagnosis. And it's a truism, but about 80% of medical diagnosis is made based on the history rather than the physical examination or any investigations. So how we extract these kind of information from patients really is a critical factor. And one thing that we learn as we go through a career in medicine is that patients that are more complicated, that are more difficult, and difficult in all kinds of ways. I mean, difficult by having bad diseases, difficult by having personalities which are challenging to interact with. They're the patients in terms of history taking where one can really learn the most. Now, In my career as a junior doctor, I had the privilege to work in a number of different centres, one here in Galway, but I also worked at a centre in the US. Some of you might know it's the Mayo Clinic in Rochester. And I went there, with a lot of enthusiasm. I was going to one of the world's really great medical institutions. I had some experience. I really wanted an academic career in medicine. I was really excited about going there. So I got there anyway, and many of the people that were there with me are still friends and are in the room here today. We were assigned to work in different clinics, and we got to meet the patients there. And one of the things that I noticed when I was there was that a lot of the patients that come to the Mayo Clinic aren't from where the Mayo Clinic is. They come from somewhere else to get a third or a fourth opinion about their illness. And if you look at people coming to the Mayo Clinic to see their doctor, they usually seem to have 2 suitcases. And this was kind of perplexing to me, because why would somebody bring 2 suitcases if they're going for a short trip to see the doctor? Well, one suitcase was for their clothing, but the other suitcase was for copies of their medical records, which they brought along for us to read. And I recall very vividly having the experience of being at in the clinic there as quite a junior trainee, and we had to see a new patient every 45 minutes. So, if anybody working in clinics here in Ireland would say 45 patients for a new patient, that's fantastic. That's lots of time. You can really go into detail with them. But at the Mayo Clinic, you also you had to talk to the patient, you had to examine them, and you had to read through inches of records from their previous hospitals and read all their x-rays and that they brought in the suitcase with them as well. So it really became a kind of a stressful event for me. So I tried to say, okay, I've got to really get all this down right. I've got to do a good job of this. So I took this really structured approach. I'm going to ask the patient about the history of their presenting complaint. I'm going to ask them every single thing about their pain. And then when I've done that, I'm going to go on and ask them about their past medical history. And then when I've done that, I'm going to ask them about their social history and their family history and what drugs they're on and what operations they've had and all the stuff that we learned in medical school. And I was trying to do this in these patients with the suitcases full of medical notes with complicated histories. And it became really, really difficult to get through everything. And I was really sweating on this problem. And eventually, after one particularly tough series of patients there, I said, I'll just give up. I'll just let the patient tell me what's wrong with them. And all of a sudden, I just let the patients go on and on. They start by telling you what doctor sent them, and they had an operation last week, and only about 10 minutes later, they tell you about what they were actually complaining of. But I learned that by listening to the patient that way and letting them tell me their story, I could actually get all the same information from them in a fraction of the time, but I just had to have a more flexible way of listening to that patient. So that was a real learning experience for me as I was going through my medical education. Now, I'm specializing primarily in the treatment of patients with a condition called inflammatory bowel disease, or a family of conditions called inflammatory bowel diseases. And this is normal over here, and this is inflammatory bowel disease over here. These are endoscopic pictures from the colon. And people that have IBD have got these ulcers in the bowel, and as you can imagine, they can be painful, and patients can have diarrhea, and they have rectal bleeding, and they lose weight, and have a lot of really, really at times terrible symptoms. Sometimes not too bad, but sometimes can be very disabling. So when we take histories from these patients with these kind of symptoms, we ask all the same sort of questions that we would normally ask. And the way the natural history of inflammatory bowel diseases in the black line here is shown by these kind of flares of disease activity. Then it might quieten down a little bit, then you have another flare, and then it might quieten down, another flares, et cetera, et cetera. And at each of these flares, patients develop symptoms. So they might have rectal bleeding, they might have pain, they might have diarrhea, and then eventually either it settles down by itself, or we introduce some treatment, and eventually it settles down as well. However, in gastroenterology, we're only really beginning to recognize this problem, which rheumatologists have known for a long time, is that it's not simple flare back to normal, flare back to normal, flare back to normal. It's flare, a bit of damage, another flare, a bit more damage, another flare, a bit more damage, and eventually patients are getting these complications of disease, which are terrible for them. Now, when we measure disease activity from patients, we talk to them when we take their histories. We've got some blood tests we can do, we've got some invasive tests we can do, we've got some stool tests, we've got urine tests, we've got x-rays and scans that we can do, and all those kind of things help us to build up a picture of how sick that patient is. And we've got disease activity indices like the CDAI it's a mathematical formula that gives us a number supposedly telling us how sick the patient is. And we can do all that kind of stuff. But the problem with it is that all the time that we're measuring these symptoms, it's usually at the peak of a disease flare. So a patient comes in, they've got this peak of symptoms. We either usually initiate some treatment and things kind of get better. But by the time that we've initiated the treatment, something as bad has happened to that patient. They've accumulated some bowel damage. So, you know, I think part of the problem of why this happens is that we're not very good at getting information from patients in the right way and quick enough to intervene early in the disease process. So I'd like to tell you just briefly about something that we're going to be doing here in Galway in the next couple of months, which is initiating a project in collaboration with many other people, including Dr. Liam Glynn in the Department of General Practice, colleagues in Scotland, Angus Watson from the University of Aberdeen, and it's funded through the Implementing Transnational Telemedicine Solutions project. This is going to be a smartphone app in which patients are going to have a daily diary in which they can record, for example, symptoms of inflammatory bowel disease like pain, like their feeling of well-being, like their bowel frequency of stools per day, and a number of other parameters which help us to measure their disease. They will upload their symptoms on a daily basis, and that will lead to a dashboard that will be provided, that will be scanned by our IBD nurse back at the hospital every day. And using this tool, we can get a pattern of symptoms. This happens to be pain, but there will also be similar ones for bowel frequencies, bleeding, etc., etc. And we'll have this kind of dashboard of a patient's activity. So what we'll begin to see, if a patient begins to have a flare of their inflammatory bowel disease, what we're going to see actually is a little bit of an uptick in the scores here, and that'll allow us to intervene in those patients more early. So what I hope we'll be able to do with this kind of technology is that we will begin to be able to implement, these arrows have shifted a little bit, but implement early when a disease flare is beginning. And therefore, if we have good treatments for IBD, which we do have in the form of a number of different drugs, we can intervene early, prevent these flare-ups going up, extending up as high on the scale as they do now, and hopefully prevent bowel damage happening to these patients, which leads to the chronic complications of this kind of chronic disease. So I think this is an example of where we can use technology to really try to help us gather information from patients better. Now, in my closing remarks, I'd like just to let you know that I think I focused on history taking and symptoms of patients, because I think that's really still very much at the core of internal medicine and the core of what we're trying to do to patients. But I'm certainly not a Luddite, and this kind of activity will not be successful unless it's encompassed within an environment which also incorporates new technology in terms of developing new drugs to treat patients, new diagnostic tests that are better and more accurate and safer for patients as well, and also in a multidisciplinary team comprising all kinds of healthcare professionals. So this kind of approach, I think, will help us and has potential to help us greatly and make patients feel very much at the center of their care as well, but only if we embed it in the right kind of environment. So with that, I'll close and really, again, thank the organisers for the opportunity to speak at a TEDMED. It's really been fun to hear all the different talks, and also to be in an environment where I think we can let loose a little bit more and tell you what we really think. So thank you for your attention.